Welcome, everyone, to the Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy counselor, and I'm joined today, as always, with Dr. Jason Martin, board-certified plastic and reconstructive surgeon. Yes, I'm digging it.
All right, so Amy, we are circling back around to a topic that is now in the news, and we had talked about this in like February or March, an episode on breast implant controversies. The topic today is related to a recall of breast implants. So what's going on?
So this, if you're listening to this after 2019, it may not seem entirely accurate. So keep that in mind. We are talking about something that is happening right now, and it's a recent FDA recall of a specific breast implant. So this is current as of August 2019. So if you're listening after, some of this data may have changed, and we'll talk about why that may be the case. But at least for now, the FDA has recalled a specific type of breast implant. And obviously, that's causing quite a bit of concern among the women who have these implants or have any implant, really.
And we've gotten a lot of calls in our office. This is a major topic in plastic surgery. So why has this recall occurred?
So the FDA, and there is wording that we will read right now directly from the FDA, from the press release, or from the FDA's press release, that says, to protect individuals from the increased risk of breast implant-associated anaplastic large cell lymphoma, which we'll abbreviate from here on out as BIA-ALCL, associated with Allergan BIOCELL textured breast implants, the Food and Drug Administration requested that Allergan recall its BIOCELL textured breast implants and tissue expanders. Allergan agreed and is removing these products from the global market. So the FDA press release on this is actually very detailed, and it does have a list of every single serial number and or name of implant that is being recalled, and it should be very much stated in the beginning that this is for non-implanted implants only. There is no active recall for implants that are implanted in a person, only for implants that are, sitting in hospitals or doctors' offices that have not been implanted.
Right, and we'll go through that because actually they do recommend, obviously, if you're symptomatic, to have it removed. BIA-ALCL, we have a whole episode or part of an episode on that, which we referenced just recently, and that is a new identifiable disease process that we're learning a lot more about. The first recorded case was in 1997. There was apparently an article in the mid-2000s, but just in the past 3 to 4 years, we're really starting to have a better understanding about that. What we know about BIA-ALCL, I would highly advise people to go on our YouTube channel, Jason Martin MD, to watch this episode because we're going to have slides that you can look at. ALCL, so anaplastic large cell lymphoma, is a known disease process that was present even before we found breast implant-associated anaplastic large cell lymphoma. The systemic form of this disease can be very aggressive and have a high mortality. The more indolent forms, or the forms that are less aggressive, have a lower mortality, have been identified before, and one of them was cutaneous ALCL, or T-cell lymphoma of the skin. Now, you and I have had a few patients, and that's a chronic condition they treat, and those patients have a high likelihood of survival and good quality of life. Breast implant-associated ALCL, which is now being identified, has some commonalities across the board. All these patients, number one, have breast implants.
Correct. And I think it's good to note that it is actually not breast cancer. So
right.
That's an important differentiator, that this is not breast cancer in the sense that it is not in the cells of the breast. It's happening in the substances around the implant itself.
Right. So the commonality in all these cases is people have a history of breast augmentation. Breast augmentation is the most common surgery we do in the United States in cosmetic surgery. I think last year, we went through these numbers before, it was over 500,000 people, 1.5 million in the world. So it's a real common surgery. And the commonality among all these patients is they have a history of having breast augmentation. I don't know for sure because we'll get to that problem, but I think most of them, or almost all of them, have breast implants in place.
Well, and it's for primary breast aug or cosmetic breast augmentation, and also for breast reconstruction.
Right.
So anyone who has a breast implant, regardless of why they have it, it's only people with a breast implant.
Right. So if you take 1.5 million had breast augmentation for cosmetic reasons, and then on top of that, you have to put all the breast reconstruction patients. And I don't have those numbers, so I'm sure it's over 2 million people in the world every year that get implanted. What they found, at least through evaluation of this disease process, is the people that get this problem or have this problem, by and large, most of them have textured breast implants. Now, we're finding more and more about this disease, and this may change over time, but a high propensity have textured breast implants. And also, they have, in most cases, what we believe is going on is an inflammatory process reacting to the breast implant itself. Why that occurs, we'll go into, but we really don't know for sure. This leads to a formation of scar tissue around the implant. We call a fibrous capsule. And then this inflammation process keeps going on and on and on. And ultimately, you develop what we call localized lymphoma, or these ALCL cells. Again, looking on the Jason Martin MG YouTube channel, you'll see actually evidence of what we're talking about. It, in a lot of cases, 2/3 of the cases, forms fluid around the implant that has lymphoma cells in there. We're not totally sure why this process occurs. One of the bigger reasons, and we talked about this a lot before in our previous podcast or episode, we think it's related to a biofilm or a low-grade contamination of the implant with bacteria. The body keeps walling it off. These bacteria persist supposedly, and you form scar tissue around the implant. This inflammatory process keeps going on like a smoldering fire. Imagine a forest fire that never gets put out, but it's really small and just keeps moving slowly, leading to this lymphoma process.
And I think this is something that most people can conceptually understand with the formation of any type of cancer. You can't catch cancer per se. It really is your own cells or your own body either attacking itself or kind of morphing, like becoming these zombie cells that start replicating in ways that are not normal, that they're abnormal. Now that can happen because of external sources, people who were radiated, people who had exposure to certain types of chemicals, smoke, nicotine. Like it can cause your cells to act abnormally, which can lead to cancer. So I think in this case as well, like it makes sense that if you have an area of the body that is chronically inflamed, your body's not happy about it, something's going on, that eventually some of these cells could become abnormal, just like they can when any other type of cancer formation starts.
Right. That inflammatory process, for whatever reason, and we don't know all the specifics, is causing those T cells that are there, okay, and T cells, and we referenced this before, were like the generals in the army,
Yeah,
right?
fighters,
They're the ones controlling this inflammatory response. Over time, they keep proliferating because the inflammation keeps going on and on and on, and something happens along the line where those T cells become abnormal. Mm-hmm. We, again, referencing a slide that we have a slide that kind of shows some of those, we know some of those mutations. One of them is the JAK and STAT3 mutation. Ultimately, it leads to these development of ALCL cells, which the test for that is a CD30. So they have to be CD30 positive, and that's, I'm not sure if it's a stain. However they do that, the pathologist does that. You take fluid out and they test it, and they say, okay, yeah, you definitely have ALCL cells present in that fluid or in a mass that they find. And that's what it is. We would love to go into this further and give people very specific information, but we really don't know the pathogenesis of this process or how this develops. And we only have understanding of different steps, so we don't have the full development idea. And the reason that is because it occurs so slowly, and that's the main thing. It's not something that occurs very quickly. It has to have this milieu of inflammation, and all these things are occurring. We believe a textured breast implant, which means the shell of the implant. We believe that maybe a biofilm or a low-grade infection in there. That means that you wouldn't even know that you had the infection or contamination at the time of surgery. And then over time, in a certain subset of people, this develops. Interesting.
It is. It's very interesting, and it's, if you're looking for the specifics on the amount of studied or documented cases, the FDA is a great resource for that, because as of now, the number is a lot higher than when we talked about this even a few months ago, because of kind of more of the statistical data being analyzed and getting rid of duplicates and, kind of narrowing down the pool essentially. And we'll talk more about that kind of toward the end, but it's not that many cases still. It's under 600 documented cases that we actually have available. So there's not a lot known. Our slides are being glitchy, and I don't know why. There we go.
Yeah. You have the way you do it is better than the way I do it.
It's just the alternate way.
Right. So here's the quick facts on this is what Amy was getting to. The first reported case was in 1997.
Which is, let's interject here.
Yeah.
When was the first time you heard about ALCL?
Oh, You mean whispers in the hallway
Right.
at the conferences? A couple years ago at the most.
Well, that's not true, though, because the first time that I was aware of it was actually the case that we had the patient who had breast implants and had the tumor under her implant, or she had the chest wall mass.
Yep.
And we were all freaked out that, oh my gosh, is it that new thing we're all hearing about, ALCL?
Right. That was 3 or 4 years. I mean, it wasn't
But
10
that
years
was-
ago.
No, but it was about 8.
No, it wasn't that long.
Was?
Okay, we can agree to disagree. Let's check the charts on that.
What year was 8 years ago?
I've known about ALCL as a physician for a while, but as it relates to a global issue,
Right.
it's been the past 3 or 4 years.
Yeah.
So the way that it was described, at least historically, was that this was a very isolated, rare event, and we're going to get to that. It is a very rare problem, but that we know of. But yeah, it was only in the past 3 or 4 years that this really became talking points at conferences. As we talked about, it's a slow developing problem. So if you've had a breast augmentation or breast reconstruction with a textured breast implant that got recalled, the median presentation is 9 years. I'm not sure how accurate that is because historically we really haven't known much about it, and maybe people weren't looking out for the problem
Or diagnosing
or
it.
diagnosing it, so people had it longer. 2/3 of the patients present with a seroma, which is fluid around the implant. So basically it's unilateral swelling, swelling on one side. And it should occur fairly precipitously, not like a day, but within a month or two where it kind of just grows and grows. Or 1/3 have a mass that's present. It's locally invasive, and this is something that's very important for people to understand. Only a very small number become metastatic for what we know right now, so less than 10%. It's a very curable problem if you treat it correctly and catch it. The treatment is removal of the breast implant and removal en bloc, or the surgical name for just complete removal of the breast capsule, which is scar tissue. They've estimated the lifetime risk at a little over 1 in 2,000, and we don't have any susceptibility tests. We will in the future. I think that some of the reason that this problem occurs more in some countries and not others, besides just the fact that some countries are better at recording things like the United States, and then we have much higher incidence of breast augmentations and breast reconstruction than most other countries, is that there's probably genetic differences. That the incidence in Africans, Asians, people of darker skin, derivation, is very low in comparison to Caucasians and Europeans. So the highest incidence has been found in New Zealand, which is very interesting too.
It is interesting.
In talking about risks, just to put this in perspective, I actually wrote this down. And if you take 1 in 2,000, okay, and we'll get into the different types of textured implants because the risk goes lower and higher depending on the type of implant, so type of texturing. So the incidence or the risk of breast cancer in a woman's lifetime is 1 in 7. Car wrecks per year is 1 in 100. Identical twins is 1 in 250. Struck by lightning is 1 in 3,000, which seemed very low to me, which makes me totally weirded out.
Well, that's actually the most common natural disaster in Colorado.
Is lightning strikes? Yeah. Oh my gosh.
Yep. You're more likely to be.
Because I've been outside when there's lightning. I'm like, you never get struck by lightning, and I don't go in, but now I'm going to go in because it's 1 in 3,000. Adverse reactions to anesthesia, which is 1 in 10,000 to 1 in 100,000. We were laughing beforehand, a royal flush, which is 1 in 649,000. Which is very unlikely to happen.
The deck really is stacked against you.
Yep. And then Powerball is 1 in 292 million. So 1 in 2,000, for what we know, and it's a little more than that, but somewhere around there, is very rare, but it's not as rare as some of these other things we talked about. So just to put it in perspective, you're a lot more likely to have identical twins. You're a lot more likely to get in a car wreck. A lot more, about as likely to get struck by lightning to have this problem. And hopefully that puts your mind in the right place to understand that this is a very rare issue that is also in most cases very treatable. Okay. Amy, what are the symptoms? So this is a big question we get because people call and they're worried that they have this problem.
Correct. And the symptoms in most cases are going to be what Dr. Martin talked about, is 2/3 are going to present with that delayed onset seroma, meaning, you are years out from your breast augmentation, you have a sudden onset or a rapid onset of one breast getting larger than the other. It's swollen, there's, you can see it, you can feel it, it's bigger. So breast enlargement, and that's typically asymmetry, so your breast is getting larger on one side. not the other. You might have pain, swelling, denoted by the change in size. Breast or armpit mass. Now that's going to be really rare that women have any mass that's palpable. It's typically a mass in the shell of the capsule itself, which would be hard to palpate.
Yeah, we don't have the numbers in that, but I bet you it's higher than you think, because if it's a localized disease against the lymph nodes, the local lymph nodes, then they could have, lymphadenopathy or,
Right.
increased size. So, but we don't have the numbers on that.
Yeah.
So that would be less likely than swelling.
Well, inflammation in your armpit makes sense if you just have any inflammation in your breast because your body's, inflamed.
Reacting to it,
Yeah.
yep.
So that might not mean you have a mass in your armpit, but just swelling in your armpit might be, expected. A rash, hardening of the implant, that we find that typical with a capsule formation. So again, anything that's causing that breast to be irritated or angry, inflamed, could also make it hard. And depending on the size of your implants and the size of your body, sometimes there's not much room to swell. So
Yep.
like when you first had your implants,
Especially in Colorado.
yeah, they feel hard because they're swollen, so they might get hard. And then a fluid collection, that's something that you can't really tell yourself without more diagnostic imaging.
So this is hard too, because besides like precipitous swelling, or if your breast swells pretty quickly and you don't have evidence of infection like redness and fevers and things like that, so they think it's just this swelling around it. The problem with this is that a lot of these symptoms are also related to things that are a lot more common, right? So for example, hardening around an implant could denote capsular contracture. The rate of capsular contracture is really high. After breast reconstruction, it's at least 30% of the patients. And if they've been radiated, it could be even higher than that. For regular breast augmentation, capsular contracture rates we talked about this in the breast augmentation episode. I want to say they're as high as 10% maybe, or maybe even higher than that. And it was over a certain amount of time frame, and maybe it's 8 years. Definitely a decent amount of people get hardening of the breast. It's a common finding we have with breast augmentation. That's cosmetic breast augmentation. And we don't totally know how to stop that. Even with all the new things we've done, the capsular contracture rate or scar tissue formation rate is still the same. So,
which, ironically enough, in the past, the theory used to be that textured implants reduced capsular contracture, and that's
which
no
is so
longer.
interesting. When I went through training, we talked about this in the previous episode. Texturing of the breast implant was supposedly useful because it decreased the ability for capsular contracture to occur. Capsular contracture is scar tissue around the implant that then contracts in, and that's because they have these myofibroblasts, which are basically like muscle cells, and cause contraction, or they cause that scar tissue to really become tight around the implant and deform that breast. And the idea is that if you have texturing, the scar tissue would grow into that and not allow those myofibroblasts to organize in a parallel way and form that severe shrinkage or contraction. But we were looking at all the data before this episode, and it's really not there. It may be subglandular, which is above the muscle, but below the muscle, really, you don't see much of a change.
No, it's statistically insignificant.
So probably the only reason in my practice personally to use a textured breast implant is if I was using a shaped breast implant and you wanted a little bit of a capsule to form so the shaped breast implant stays perfectly situated. It doesn't rotate, it doesn't shift. Whereas a round breast implant, you could listen to our breast augmentation episode. If it rotates a little bit, it doesn't matter because it's round. It's not going to change the way it looks on the breast. But I personally, in my cosmetic surgery practice, never used textured breast implants for just a standard breast augmentation procedure. So we know that it's a pretty uncommon problem. We also know that it's treatable. So all those people listening or watching this, please know that there's an answer if, God forbid, you ever had this problem, and in most cases, it's treatable. The first thing you need to do if you're concerned about having this problem is get a physical exam, right? Go see your doctor.
Go see your doctor, yeah.
I mean, even if it's your internist, if you can't see your plastic surgeon.
Or OBGYN.
OBGYN, you see them, say, hey, I'm concerned about this problem. Can you examine me? Someone who has comfort in doing breast exams for clinical reasons.
Yeah, and that's why your OB might be a great place to start. You should be having a regular checkup anyway. Whether you have implants or not, they're still doing a breast exam on you every year. So, that's a good place to start if you can't get back to your operating surgeon.
Right. If you think that you have, or if the physician thinks the patient has ALCL, or they're concerned, you would never really know from a physical exam, you would just have some concerns, then you would most likely order an ultrasound. An ultrasound is going to be able to visualize the breast implant and if there's any fluid around it. If there is fluid, you could do something called a fine needle aspiration, or stick a needle in and aspirate the fluid out. You would send that fluid off to the pathologist, check it for the CD30, and see if it's CD30 positive, and then you would have a definitive diagnosis. If the ultrasound is not helpful or maybe confusing, you could also order an MRI. Mm-hmm. But the main way to diagnose this problem is to actually send fluid or tissue off and see if it has ALCL cells in there. Mm-hmm. And I talked to the pathologist this week. It's not super easy to do that, right? So it has to be coordinated. You have to go to people that are comfortable with this and have a pathology lab that actually is able to process these tests.
Right, and also have ordered it that way. I mean, most fluid samples that we send off to a lab, or in common situations, are going to be to test for antibiotic susceptibility and or infection.
Right.
So they're going to test them for white blood cells. They're going to test them for microbial growth, fungal growth.
Even certain other types of cancers, like breast cancers. Mm-hmm. We had a case like that.
Yeah,
she kept having kept having a seroma, and she had a previous history of breast cancer with a mastectomy. I believe it was a mastectomy.
Yeah.
And the fluid kept coming back, and we tested it, the fluid, and it came back negative, and we finally tested. I just didn't stop testing it because I knew something was wrong. We tested it again, and ultimately it came back positive for recurrence of breast cancer.
Yeah.
So again, across the United States and the world up until now, this was not a commonly known issue. You can go to some doctors and ask them about breast implant-associated anaplastic large cell lymphoma, even plastic surgeons, and they may not know a lot about it.
Or how to diagnose it.
So physical exam, ultrasound with an aspiration, so that's taking some of the fluid out, or an MRI with some sort of tissue biopsy, and then send that off to the pathologist to see what the ALK status is. That would be negative, and the CD30 would be positive. Okay? So, again, looking on our YouTube channel, what we don't know about BIA-ALCL is so much. So,
you mean what we know don't?
Yeah, exactly. What we know don't. But in preparing for this, we wanted to make sure that we were fair to everyone watching this and alleviate some of the fears that are out there. But we have to also be honest and say that there are a lot of things we don't know. Just to kind of summarize a little bit, we know, and I'm going to restate what I said before, and Amy can chime in whenever, we know that in most of these cases, a high majority, they have textured breast implants. Texturing of a breast implant is related to the shell, the covering of the implant. It could be a saline breast implant or a silicone breast implant. If it's textured, that means the outside is a little bit rough, right, Amy?
Mm-hmm.
Okay. So the implants that got recalled were from Allergan, just by chance, or not just by what they evaluated from the data. And those had a BIOCELL covering, which was a certain type of texturing, which I think they did salt loss.
We'll talk about that in a
Okay,
minute.
Good, yeah. There are other manufacturers of breast implants, which we're going to talk about, and they have textured implants. But the texturing process is a little bit different, so we'll go there. But the main thing we want to talk about, and what I think is really important, is what we really don't know is a lot. So if you know odds or a fraction, and I know this because of working with my daughter. Now she's in high school, so now I'm working with my son. So you have to have a numerator and a denominator, right? So the denominator in this situation would be all people with breast implants, right? Every single person in the history of breast augmentation or breast reconstruction that has some sort of breast implant. And the numerator would be the number of people or the number of cases of BIA-ALCL. And that's how we could get a percentage. Right now we're saying 1 in 2,200, 2,800, whatever. But that may go up or down depending how we improve getting a denominator and numerator. So Amy, kind of go through that real quick, why we don't know totally. What are the issues we have by getting an accurate numerator and an accurate denominator?
Let's start with the denominator. So that would be the number of women with implants. Part of the problem is that it's cosmetic, it's self-pay, it's unregulated. There's been a recent boom in cosmetic procedures, and also it's globally.
Especially in Asia and places like that, where they do not track stuff as well.
Correct. So it's not really it's not globally regulated. So there may be individual countries regulating it in their certain way, but There's not a full disclosure sharing of information.
To that point, in the United States, they did have a recall of silicone breast implants in the early 2000s, late 1990s. So we have a pretty good tracking system since they've allowed silicone breast implants back on the market. Not perfect, but pretty darn good.
It's self-reported.
It's self-reported, but the surgical facilities have to send things in, or at least they're required to. So we're better than most countries, but it doesn't mean that it's perfect.
Correct, and we're better recently. And again, the average time to diagnosis is 9 years, so we're better in the last 15. But we really just don't know, and that's part of it. Manufacturers, there is a reluctancy to release data, as how it was put in this article, which absolutely, right? But there's no true registration. Even the one company technically did this long-term study that was supposed to be 10 years. Well, they didn't complete it. So, and the compliance rate was extremely low on the patients who were enrolled and did stay in. It required a lot of tracking that they just never did. So, bias, fear of implication. These are all things that might affect the manufacturer's desire,
or even the surgeons. I mean,
exactly.
The surgeon may feel they have some culpability. They may not report things.
Correct.
And just so you know, there is a national registry for ALCL, breast implant-associated, and also an international registry. So they're collecting more and more data
and
daily.
These things were started just this year. Implant specifics is another thing we just don't know. Again, if we don't know how many people have these implants, we don't know specifically what type, what material, what surface texturing they have. So many things we just don't know about the implant specifics. And this is, of course, worldwide. So a lot we don't know just about who even has implants in place. Then the numerator is, of course, the amount of cases of BIA-ALCL. Some challenges there are going to be the clinical presentation, delayed onset, 9 to 10 years average. Subclinical, meaning that you don't maybe have a fever. There's challenges in just understanding what your symptoms might be. Somewhat nonspecific. And there may be, especially in the past, have been a lack of follow-up. That's something that I've kind of wondered as more of this has come to light. How many women had their breast implants removed and replaced, removed entirely, maybe had the capsule removed, maybe didn't, who knows if this is persisting in them? Don't know.
This is a huge problem because, up to this point, it really wasn't in our sensorium, right? We weren't totally aware of this. How many capsule removals and implant exchanges were done where they took out a textured breast implant and put a smooth in?
Yeah.
And then it solved the problem.
Right, and didn't take the capsule out.
So we haven't gotten to the treatment yet, but exactly. So these things could be done, and they were never reported.
Right, and no one's tracking them.
Or they were sent to a pathology lab that didn't have the ability to fully do the appropriate workup for CD30 positive and ALK negative.
Yeah, didn't even know to do that. Like I said, most fluid samples sent to the lab, unless you specify it, are only going to be tested for bacterial growth.
Right.
So they may have tested it, but just not have found anything because they weren't looking for it. So that's a big roadblock there. Lack of awareness in patients and doctors. We just talked about misdiagnosis, underreporting again, surgeon denial.
So if you think about it, and I'm going to say this in a way that's cohesive and not problematic, but if you think about the most common surgery we do in the United States in cosmetic surgery is breast augmentation. Clearly, people that have a whole practice based on breast augmentation would inherently, just from human nature, want to not believe that a small number of these could get this weird lymphoma, right? It's just, that's what they do for a living.
Yep, the same bias that exists with the manufacturer could absolutely exist with the doctor.
So,
and with the patient too.
And you could see where all these things make a perfect storm, something like BIA-ALCL, which again is very rare, very uncommon and treatable. Okay,
Yeah.
So we have a problem with the numerator. We have a problem with the denominator, so these numbers that are coming out could definitely change.
Correct. And just two more quick things to bring up. We talked about the registry. In the past, there has been no registry. There is now. Fear of litigation. Obviously, all these companies are afraid of being sued. Doctors are afraid of being sued. Like, there were reasons why no one was really keeping great record. It's easier just to not keep a record of something you're concerned about.
I just want to say, I just want to be real clear, I don't think it was
malicious.
Yeah, okay.
No, not at all. I don't think it was malicious. I think people just, when all you've ever seen is something positive, you don't see the negative until it's so big sometimes, So, and then of course, patient specifics, we still don't know if there's a genetic component. Obviously, the way people methylate, the way their genes function, those are all things like we talked about at the beginning. The reason that you develop any type of cancer, there's so many genetic types of cancer.
There's Lee-Fraumeni syndrome, which is I learned about in medical school, has a higher propensity of having BIA-ALCL. That's a P53 oncogene. I mean, you can nerd out and look all that up. clearly there's why is this occurring in more Caucasian heavy countries? They obviously have some genetic thing there that's causing chronic inflammation around an implant that maybe has a biofilm or a low-grade infection and also a capsule.
Or co-contributing lifestyle factors. I mean, of course, I go there because I love epigenetics.
You gotta throw the Americans under the bus.
No, I'm not saying Americans.
Listen,
you said it happens more in Australia or New Zealand.
There's some Asian countries that just not by their doing don't have the best, health.
I'm not saying this has anything to do with Americans.
Okay.
I'm just saying that, that's the things we don't know culturally.
We don't know.
We just don't know.
Yeah.
There's a lot to be learned.
Should I have my implants removed
The
or
million-dollar question.
replaced? How many phone calls have we had on this?
Oh, in just the last 2 weeks, I'd say several dozen. And
Yeah.
that doesn't, we also posted about this on our Instagram. We had patients reaching out to us, not our patients, women reaching out to us who had breast implants. And that's, of course, your first thought is, oh my gosh, I have a ticking time bomb on my chest. I need to get it out as quickly as possible.
Especially a breast cancer survivor. Mm-hmm. You can totally understand their mindset. Like, you went through this terrible situation. You were like that 1 in 7 woman that gets breast cancer. You survived it, and now your surgeon opted to use the implant that was recalled that supposedly causes lymphoma. That's what they hear, okay? And you can completely understand the anxiety and stress related to that. I totally get it.
Yeah, absolutely.
Yeah, and I would, if I was them, I would absolutely call my surgeon right away.
I would too. If you beat cancer once, you want to know what you're up against. Again, possibly.
So it's important to note a few things. We mentioned this before and we'll go into it again. So what makes an implant textured? We have an episode on, did we talk about this in the controversies part, or is this breast augmentation?
We've talked about it in both. Of course, we talked about it in controversies because we talked about why textured implants were seen to have perhaps a better rate of capsular contracture. We talked about it in the different types of implants that are available.
Yeah, I think whatever episode was on the types of implants that are available or selecting an implant, I believe we talked about the manufacturing process. So in its basic form, these implants are made out of silicone, the shell itself. They're filled with saline or silicone. Silicone are by far superior breast implants than saline. You can listen to that episode and understand why. Most implants, or a majority of the implants we implant in the United States and worldwide, are smooth shelled, meaning they don't have any texturing on them. And texturing would be like sandpaper on the outside, not that rough, but you have different mills or different grades of sandpaper. It's a lighter, it's not super rough, but it's definitely rough to the touch. Now, the texturing process occurs during the manufacturing process. They have something called a mandrel, which I love the name because not very often do you get to say the word mandrel. Okay, and they dip it into the silicone and form the shell. And actually, I think Mentor does it with robots. We talked about that.
Santra does it with robots, I thought.
No, it's Mentor.
It's Mentor. Oh,
Mentor
okay.
uses the robots.
They're the robot users.
Anyways, once the shell is somewhat formed, there's different ways to texture it. I think Allergan did a salt loss. Mentor does imprinting. And Sientra does gas diffusion with ammonium carbonate. So they heat it up and then the gas diffuses and leaves this kind of texturing. The ammonium carbonate diffuses as gas and leaves a little texturing on there. But what they found, at least so far, and again, we're going to be really limited on reporting data because there's so much stuff coming in. And Amy, you can correct me if I'm wrong. They found basically that implants that have a greater amount of texturing, right, or more rough texturing or more surface area in their texturing, bigger peaks and valleys and more aggressive texturing have a higher association with ALCL. Is that correct?
Correct. And the current data says that it's about 6 times more likely. So it's not a huge amount more, but it is enough more that's significant, statistically significant difference.
So the implants that are being recalled, the Allergan BIOCELL implants, of the 573 unique cases reported per the FDA release, greater than 80% were with the BIOCELL brand, which is Allergan, which is the salt loss method of texturing, which has the most surface area, most roughness of all the textured implants that were out there, at least of the major manufacturers. Is that correct?
It is in this country.
Okay.
Yes.
So now we get into that weird slippery slope is like whose texturing is better than whose texturing, right? You can go to different studies and show things, but just so you know that's why the BIOCELLs were singled out, because at least with the data we have, they had a higher incidence of ALCL associated. 80% of the cases known cases were with BIOCELL. 80% of the known ALCL cases were with BIOCELL implants. That's why texturing matters. The other manufacturers, Mentor and Sientra, have lower incidence of, per the data that we have a lower incidence of BIA-ALCL, but is that because their reporting is less? Is that because they were used less? Allergan, in some ways, had maybe more distribution globally. Who knows? So texturing, at least for what we know right now, does make a difference, but we don't know all the details. So to sit here and say some implants better than others, use this or that, to be honest with you, if I'm going to advise a patient, I would say just don't use textured breast implants for now. Use smooth breast implants or smooth tissue expanders moving forward until we get more data to understand what's going on. Is that a reasonable advice?
Oh,
okay.
yeah. I think I would advise a patient the same way. And, something interesting with breast implants in general, and the implants that have been recalled now cover implants that were manufactured by a company that Allergan purchased. So not even implants that were manufactured by Allergan themselves. So this type of texturing has been used by other companies. So if you have a McGann implant, it may be one of the recalled. And that's why it's important, the first step is to know your implant, know what type of implant you have. Check your implant device cards. If you have lost them or don't have them, call your doctor, call your operating facility. Now, unfortunately, medical records are only required to be kept for 7 years. So if your implants are in that 10 plus year range and you don't know what they are, it's why it's very important to keep your device cards. If you have newly been implanted, make sure you get those. You should have gotten them from the facility. Your doctor should also have a copy. It's important to know that because this way you can cross-reference with the list that the FDA has provided of the recalled implants, because they do include implants that are not labeled as Allergan implants. There's some of the old McGann implants as well. So there's a lot of challenging factors here, and that's why we have said that it's not just silicone. So this is not a silicone related issue. This is tissue expanders. This is saline implants. So it's a lot of implants. So I don't want people to be afraid of a specific type, that it's just silicone. It's not. It's saline too. It's tissue expanders. It could be a lot of things.
So should you get your implants removed, first find out what implants you have in place. That's what Amy's saying. Second thing, find out if they're textured. Okay, if they are textured, then you know that you would have an increased risk of having BIA-ALCL, understanding that it's an extremely rare condition. Then you go to look at what the symptoms are, because the FDA recommended only removal if the patients are symptomatic. We talked about that in this episode, so go reference that again. But 2/3 are swelling on one side or the other, and 1/3 have a mass. If you feel like you have those, you need to go see your physician, have the physician evaluate you, and most likely, if there's any concern, they will get an ultrasound, especially if there's swelling, to see if they can aspirate some fluid out or remove some fluid and test that, or they'll get an MRI. If those things come back positive, then of course you need to have it removed. And that's where you get into the treatment of BIA-ALCL, which we talk a lot about in our previous podcast. But basically, it involves removing the implant, removing the scar tissue, and in some cases, not every case, you would get chemotherapy. I talked to the oncologist this week that I work with, Dr. Urquhart, who's excellent. He said not everyone would get chemotherapy, which I may have referenced that in the previous episode, but it's only case-per-case basis.
I mean, I'm sure you would still do a sentinel node biopsy just to make sure?
No? It's... some of that has not been delineated. I talked to the surgical oncologist. They didn't really have reference on that. So I think you would have to get a workup and then go to a place where they have a multidisciplinary team with an oncologist, a surgical oncologist, specifically with breast focus, a plastic surgeon, a radiation oncologist, and a pathologist that meet together and could really work through this. I highly advise that.
Yeah.
That's my recommendation.
That's what I would want as a patient too. I mean, I'd want a PET scan just to be sure.
Right.
Like, I'll take the dose of radiation. Let's just make sure that there's nothing else out there.
Yeah.
But I think that's the same thought that you said with patients who are previous breast cancer survivors. I mean, your first thought when you hear of any other type of cancer that you could have or could be susceptible to, like, let's scan it out. But that's something we didn't actually touch on. Well, we kind of did, but there is no susceptibility test. So you could be coming up clear on your PET scan, technically, right? If you're not having fluid, what if you don't have fluid? Does that mean you don't have it? Not necessarily. We just don't know. So
Yeah.
there will be, I think it'll be interesting to see, and I texted this to Dr. Martin last night actually, is just how much we're going to learn about this disease, its prevention, its treatment, its lifespan essentially, you know, how it's diagnosed, how it's treated in the coming years.
I do think it's important to tell all patients that are concerned that as this is extremely rare, and I keep saying that over and over to hopefully quell some anxiety with people, that you know, the likelihood of any patient that comes to my office having this problem is very, very small. And if they did have that problem, it is in almost all cases treatable. You know, less than 10% have a real problem, and that's great. So that means it's a really treatable disease. According to the oncologists I work with, most of those cases will not need chemotherapy. The only thing they'll need is removal of the scar tissue in the breast implant, and they'll be healthy and on their way.
Yeah, follow-up monitoring.
Right.
Yeah.
We personally, Amy and I personally understand, especially patients who've had a history of breast cancer, why this would elevate the anxiety so much. And recently, Allergan, at the very least, gave a warranty. They said within 2 years of their announcement, so June 24th of 2019, they would cover the cost of the breast implant if there was some concern that they may have this problem. They didn't. I'm not sure how that was worded. If you have to have diagnosed ALCL, I didn't think it was worded that way.
No, you do have to have one of the recalled implants, and they only cover the replacement implant. They do not cover surgeon's fees, OR fees, anesthesia, anything else. But they will give you a new set of implants, smooth implants,
which
to
is
replace
a start.
your textured. Yeah.
But if you've had breast cancer, your insurance may not cover that just out of concern that you may have this rare condition. And if you are a cosmetic patient, the insurance company may not cover it because they said that this is a cosmetic procedure. So you have no diagnosed problem.
Right. It is still elective.
So we're in this weird gray area now for patients who want to get things done. And in reality, if you don't have a diagnosed problem, it creates even more confusion. So that's why I just really implore people to go with a reputable surgeon, sit down and talk with them, make a game plan, figure this out, and kind of move on from there. If you're nervous and anxious at home, you know, we're here to help. We'd love to see you, but definitely go see your operative surgeon. Go see your OBGYN that you respect, someone that you know can take care of you well, and kind of make a game plan for this. I think that's the best advice we can give.
Yep, I agree.
And know that if you take odds, you're going to be good, right? So just looking at the odds, the chances of you having this problem are extremely, extremely, extremely small. When you hear a press release and it's on the news and everyone says that all these implants are recalled, they're like, oh my gosh. But if you get down into the details of it, it's not as hugely problematic from the number standpoint. It's just problematic for the patient standpoint and how they feel. And we get that. And that's why we did this podcast.
Yeah. How many people do you know that have been struck by lightning?
Nobody?
Nils? I know one. It was when I was a kid. One of my friends.
Did they make it?
Yeah, it was their dad and maybe one of the other siblings that they had taken shelter in a storm here. This is what shows I'm from Colorado. Of course, I know someone who's been struck by lightning.
Actually, that's not true. They don't know for sure, but there was a local obstetrics doctor who was really athletic and was paddleboarding and basically drowned. Did you see that? Yeah, and they think that was a lightning strike.
Do you know that person personally, though?
Excuse me?
Do you know that doctor personally?
Mm-mm.
No. So that's been somebody that we knew personally.
No.
How many have you gotten a royal flush? Playing card poker, not computer.
I'm so bad at poker. I play euchre. I played euchre this past week, and everyone was making fun of me the whole time. So
no.
I've never had a royal flush. I've had two of a kind.
I've had two of a kind. Yeah. Nils said he's had one playing real cards. Yeah.
I don't believe it.
So
I think he's grandstanding.
You know, I mean, but that just really more proof that like these things are more, it's rare that 3 people in a room know someone who has even been struck by lightning. So yeah, that's it. So thank you all for listening. If you're interested in seeing the slides and video associated with this podcast, you can find that on our YouTube page, Jason Martin, MD. We're also on Instagram at Beauty and the Surgeon Podcast and at Jason Martin, MD.
Also, rank and rate this podcast. It's really helpful for us because this is an educational podcast, as is evidenced by this episode. And we try to get real information out there for people that are considering cosmetic surgery, that maybe have had reconstructive surgery, things related to plastic surgery, but actually things related to health and fitness in your life. So please rank and rate us. Also, if you have any specific questions, you can definitely email our office But again, I just want to say one more time, we would highly advise that you reach out to a physician that is treating you, because they have an intimate relationship with you, and they can create a treatment plan or a plan of evaluation that really fits who you are in the hospital system you're in.
All right. Thanks, everyone.
Thank you very much.